we're going to focus more on the spinal portion today, and then we'll cover brain when we deep dive into cranial nerves. And so, as a quick reminder, we have our veterinary patients. Let's go ahead and get some drawing on here, right? I'm not a good drawer, so I don't judge you. You don't judge me, and we all live happily ever after. All right, kind of looks like PBS Arthur there, who we're talking about today. And of course, everyone's got to have legs, everyone has to have a tail, and you all know what that is. All right, so as we break down, it is no surprise to anyone, right? We're going to have our C1, C5, our C6, T2, T3, L3, L4, S1, and then S1 to S3. Now, depending on where you were taught or how you're trained, that L4 to S3 may be inclusive. However, I would argue that if we're going to be at that higher level, that specialist level, especially if you're dealing with issues of the urinary system, we need to be aware that S1, S2, S3 can present as its own specific localization with a normal ambulating patient. And so for me, it is very important that we recognize that an L4-S1 and an S1-S3 patient can present differently. So you might ask, well, why the heck then does everyone teach it L4 to S3? It's all about real estate. So when we look at L4 to S3, all of those neurons are really, really close together. Whereas when we look higher up, there's a lot more space between those neurons and the different spinal cord segments. But S1, S3 really is tucked in there right beside L7, L6, and they're just really much smaller in real estate. And so we'll kind of deep dive into that a little bit because it does matter clinically. So as we go in, we'll start looking and we'll deep dive into all of those. Now, I want to take a little bit of a more advanced approach to this rather than just there's the brain, there's the spinal cord, all of this. I want to talk a little bit about the why, because that's what separates us a little bit from other, groups that do neurolocalization, is understanding that why, okay? So as we look through, remember that we have two locations for those upper motor neurons. And upper motor neurons, as a reminder, are going to be the supervisors or the parents of the nervous system. They're the ones who actually get to make decisions. And so if I am a human, we have the majority of our upper motor neuron input coming from our cortex. We are very pyramidal-based systems, which means we use a lot of our prefrontal cortex for decision-making, for ambulating, things like that. And so this is going to be our cortical upper motor neurons. In comparison, our veterinary species, that was weird, are going to have brainstem, upper motor neuron control, all right? And this is going to be an extra pyramidal pathway. And all I'm meaning is when I'm saying pyramidal or extra pyramidal is where those spinal tracts run through the brainstem, all right? So the cortical spinal tracts, they're going to run through that portion of the brainstem known as the pyramids. The other ones, because they're originating from the brainstem, are not as external like the pyramidal tracts are, which if you flip the brain over, you'll see those two pyramids underneath. These extrapyramidal ones are actually running through the brainstem because they have to get to those nuclei, and anatomically, there's just not enough space to get there externally. And so these are the two locations for upper motor neuron input. Now, I want to be clear. No animal runs solely on cortical or brainstem upper motor neuron input, okay? Dogs and cats who are quadrupeds, who have brainstem upper motor neuron as their primary gait generation location, these animals still have upper motor neuron cortices, right? Which is great. We want that because we want them to run to us and be happy when they see us, right? And make movements based on emotions and decisions. However, we also use our brainstem upper motor neuron. And I can give you an example. If you're walking down a nice, solid, flat thing, maybe you're out on a walk on the road, nice, flat, easy going, you don't have to think too much about walking, do you? But if you're out on a rough terrain, hilly route step, every step now, you're slowly placing your foot in a very calculated way. That's the difference between upper motor neuron and lower motor, or that, sorry, upper motor neuron cortices and brainstem upper motor neuron. Is this more pattern generation and I'm going into auto mode? Or am I actually consciously thinking about how I'm placing? Am I taking in, interpreting that proprioceptive information and making decisions accurately based on that? Again, not something we need to dive deep into, but again, this explains some of the how of the clinical signs we get a little bit later. Now, before we deep dive into how these connect to the system, the other big thing I want you to know about is those lower motor neurons. Those lower motor neurons are either the factory worker or they are the children, depending on what analogy works best for you. Remember, we said that upper motor neurons were going to be our supervisors or our parents. Well, these lower motor neurons are either our working class or our children, again, depending on which analogy works best for you. What I want you to be aware of is that we have lower motor, I'm sorry, this looks too close to yellow. Let's choose something different. I guess we're going red. All right, I'm running out of color. So these lower motor neurons live also in the brainstem. The lower motor neurons of the brainstem are what control the cranial nerves. And again, we're going to deep dive into cranial nerves at the next session I'm with you. So again, we're going to focus on spine today. But remember that the brainstem is a conglomerate of both these upper motor neuron systems and lower motor neurons that control the cranial nerves and some of the other functions of that brainstem locally in the head. Once we get now to the spine, here's something that people forget. We have lower motor neurons located throughout the entire spinal cord. Now, why do we say that only lower motor neuron signs of dysfunction occur at the legs? Because nobody cares about a dog having a six-pack. All right? If I go in and I cut the nerve roots here, nobody cares that my dog doesn't have a six-pack abs or eight-pack or nine-pack, depending on, how big that dog is and some of the animation. So we just don't care clinically. Now, you can see signs of lower motor neuron dysfunction at these, what are traditionally those upper motor neurons, C1, C5, T3, L3 of these upper motor neuron, and I'm using air quotes for those of you on Zoom who can't see me, upper motor neuron lesions. It's just that we don't see them as pronounced. You can get muscle laxity in the neck. You can get muscle laxity in the abdomen. Again, they just don't show up as pronounced clinically. That's why we don't really care about them so much. And that's why lower motor neuron signs show up mostly at C6, T2, and that L4 to S3. As we continue down, now the question becomes, how do these connect? Well, that cortical upper motor neuron is going to have a primary track, and that primary track is going to come down, go through the brainstem, and then go down onto all of these neurons, depending on what functionality it is. Now, quick little asterisk, we're not going to deep dive into it today. There is cerebellar oversight. And so what really happens is it comes down here to the brainstem, it goes up to the cerebellum, leaves the cerebellum, goes back up here, helps regulate that, but also goes down there. So we won't deep dive into how the cerebellum modulates all of these corticospinal tracts, but just know that it does have to be involved in the decision making because the cerebellum is always aware of our proprioception. It is the house for unconscious proprioception. Whereas our cortex is the home of conscious proprioception. Which is why, if I ever hear you use the term as a specialist, conscious proprioception, I'm going to be highly disappointed in you. because there is no test that definitively discerns between conscious and unconscious proprioception. Remember, unconscious is cerebellum, conscious is cerebrum. So when we're testing proprioception with our paw placing, our hopping, we're testing both conscious and unconscious proprioception at the same time. Now, in all fairness, conscious proprioception is the bigger of the two, right? It's going to make the biggest movements because we know that because not all cerebellar disease causes proprioceptive lesions. So again, just something to keep in mind. Why do neurologists get so upheld about this term conscious proprioception? That's why. So welcome, you're now inundated, you're now part of the club of the knowing. So as we go through, this blue track here is going to represent that corticospinal tract. There's corticopontine, that's the tract that's going to go down to the cerebellum and help with regulation. But the corticospinal tract equals the primary motor tract for humans. In comparison, if we start looking now at our green tract here, this green tract that again does the same thing, goes all the way down. This is going to be our rubrospinal tract. This is the primary tract for quadrupeds. And again, you can think of that corticospinal or that cortical upper motor neuron as being pyramidal system, and that lower rubrospinal tract as being our extrapyramidal systems, again, kind of discerning between higher order species and lower. However, when we have species variants that are beyond the cat, the dog, and we move into things like raccoons. When we think of raccoons, the big thing that we all know about them, they got great little paws, right? They can do a lot of great things, open up trash cans, ruin campsites, and make everyone really, really sad the next morning. With that high level motor movement means that they have more of this cortical upper motor neuron input, at least into the level of their forearms. Horses, in contrast, have a lot of this upper motor neuron input from the cortex in their muzzle, right? They're so facially expressed. They use that muzzle for all sorts of things, including prehension and grabbing, much more than our dog and cat species. Well, guess what? They have a lot more of this cortical input from this pyramidal pathway going into their face than other species do. So you can see some species variants. Cats have just a titch more than dogs, right? That's what makes them so much more agile at knocking things off of our counters compared to dogs who just use their bodies and tails. And so there will be variances as we go through different species. Now, as we start looking at what happens when these systems are damaged, this entire process, the reason that this is so important is because this is how we explain the differences of neurological presentation to our owners. Because when you think of a stroke in a human, you automatically probably think of facial paresis, limp side, dragging of the limbs, and loss of motor movement. When we think of veterinary species, this is not so much the case. Our forebrain lesions, like brain tumors, some vascular, though really severe vascular global strokes don't count, but a lot of these strokes do not cause weakness in the limbs of our species. This is why. Because if I damage that cortical upper motor neuron input, I really don't care too much in terms of gait generation. Where you and I would have trouble walking after a stroke, to our prefrontal cortex, a dog may circle, but they're going to have strength. And that is all because that their primary motor function is coming from that brainstem. And so when we talk about gait generation and we talk about evaluating gait, when you start to see weakness, remember that weakness is going to be affecting those motor tracts that either is coming from the brainstem or from the spinal cord. Again, if you have a really severe lesion, if you have a global ischemia, if you have a really big lesion that shocks the system, like an acute bleed that then dramatically changes the brain, you're going to have weakness. And a lot of that's going to be because of the pressure that's pushing down on the brainstem. However, you can shock this system. So as we keep deep diving in, now we start getting into what do these lesions look like. I'll save brainstem and cortical. We'll talk about, again, all that with the cranial nerves because that's where they're more salient. But I want to talk about getting into each of these. Now, some of you were probably trained with this idea of upper motor neuron signs versus lower motor neuron signs. That terminology has horrible foundations when we talk about grammar and English dictation and description, right? Because when you say the word upper motor neuron signs, you are thinking, oh, I'm seeing the upper motor neuron function. But in reality, when we say upper motor neuron signs, we're saying the upper motor neuron system's broken. And it doesn't make sense. And so I am encouraging, as we're training students, to drop that terminology and start adding, and not really drop it, but add in more that says upper motor neuron signs of dysfunction. That of dysfunction helps our young learners to better understand, oh, these are the signs that are present when that system is damaged. Not that these upper motor neuron signs are showing through. And that's how that terminology presents, is that, oh, upper motor neuron signs means the upper motor neuron functions are showing through. It actually means the opposite. So I will use the term upper motor neuron or lower motor neuron signs of dysfunction as we go through this, okay? So when we have a lesion here, we're going to call this lesion 1. When I have lesion 1 here, and we're going to look at our upper motor neuron signs of dysfunction and our lower motor neuron signs of dysfunction. What we'll see is that with a C1, C5 lesion, there, of course, can be everything from mild pain and discomfort. That's going to be usually the first clinical sign we see. Then what we'll start to see there is progress on now with ataxia. It is vitally important for you to remember that ataxia is different than paresis. Paresis is weakness. That is a motor issue. Proprioception and sensory and all of that, that is going to be more of our sensory system, and that's going to be where ataxia is, that lack of knowledge of knowing where our feet are. When we have a lesion at C1, C5, we're dealing with that proprioceptive ataxia, what is probably known to many people as spinal ataxia, which is complete baloney, because if I have a brainstem lesion, I can also get spinal ataxia. And so it doesn't quite actually work with the terminology, so we call it proprioceptive ataxia. But remember, I can have other two types. I can have that vestibular ataxia, and I can have that cerebellar ataxia. And so as we deep dive in, oh, thank you, Levin Good. I appreciate that. She put in the chat that some of that terminology had been difficult. And yeah, so 100%. It messed me up. I didn't get neuro until like 4th year. And I was like, oh, they've been saying it wrong. So know that you are in good company. That's why I like to do this. So as we go through and we start looking at that, we're going to have the pain first. And then as we cause a more compressive lesion, now we're going to start getting some of that ataxia. Why do we get that ataxia first? It's because the proprioceptive pathways are 1, big, and 2, heavy myelinated. And so I want you to think of this. If you are to lay your head down on a pillow, and it's a big, fluffy, grandiose pillow, how much does your head sink into that pillow? Probably a lot, right? Now, if you go get one of these cheap $2 dollar store pillows that are super flat and have no fluff in them, right? It's like, did they build this with a piece of wood? That, or, like a patio seat or things like that, very thin. You put your head on there, there's very little compression. Well, our proprioceptive tracts are like these big, fluffy pillows. They're really prone to compression. And so when I compress that, I'm compressing this really large axon that has a ton of myelination. When I start getting deeper and I start losing motor, well, motor is going to be there in the middle. It's got mid-sized axons, middle ground myelination. And then as we keep going, then I'm going to get into that spinothalamic pathway. That spinothalamic pathway, that is where a lot of our sensory information coming in, like deep pain. That deep pain is going to travel up that spinal cord. And what's nice about this is like that crappy patio pillow. It is very, very thin, very small axons, and very low myelination, which means it does not compress very, very well. And that's what makes it so late stage, and that's what helps us with prognosis, is because if that puppy's compressed, oh boy, we got to have a lot of compression going on. And so that is how we see these clinical signs kind of progress over time: pain, then ataxia, then paresis, and then we have loss of deep pain. Now, you will hear some neurologists separate out superficial and deep pain. I'm going, I don't. I just say, do they got the deep pain or they not? If they got the superficial, it doesn't really mean much to me if the deep pain is there or isn't, because already now we're moving into it, and superficial can be so, there's a subjective, objective type component there. Like, did they feel it? Did they not? Are they stoic? Aren't they? And again, it just doesn't give me much information. So if I'm going to pitch them and hurt them, let me just do it once and measure for deep pain. That's my personal opinion. And prognostic information has never been reported well on superficial because everyone tested a little bit differently. So again, some people separate them out. I don't. I just go to deep pain and say yes or no. I try to simplify this as much as I can because I'm a real dummy. So I need it simple. So as we look at those clinical signs and we start talking about, okay, when I lose signal to these lower motor neurons, or I lose this signal, what's happening? And this is where we start getting into that terminology of upper motor neuron signs of dysfunction, lower motor neuron signs of dysfunction. Because if I have a lesion here at C1, C5, and we look to see what I'm damaging, what you can see here is I am damaging those lower motor neurons of the spinal cord. However, do we care about the lower motor neurons in the neck? Nah, not really. Right now, we do at end stage, right? The phrenic nerve and all those guys, sure, yeah, it does have a place. But for most compressive lesions, we don't. And then we're going to see that our injury is also affecting the tract. So we are damaging lower motor neurons locally, but more importantly, we're damaging these upper motor neuron tracts as they go down to the limbs. Now, I told you that these lower motor neurons are going to be like the children, right? And so upper motor neurons, upper motor neurons make decisions, but they cannot actually work the equipment. If you don't have a lower motor neuron involved, you cannot move the limb, period. As much as the upper motor neuron wants it, right? And this makes sense, right? As much as a supervisor wants a job done, does it mean that they know how to do it, or at least do it well? Heck no, right? You need the workers, especially when you're dealing with like factory machines and things like that. Down here, we're going to have our workers, and these guys are going to facilitate movement and tone and reflexes. So to have motor movement, as you can see, I need both some sort of upper motor neuron movement. I'm sorry, this is supposed to go from the lower motor neurons. I don't really have a good lower motor neuron in here, so let me just put it here. Lower motor neuron. Sorry for the confusion. And so these brainstem and these cortical upper motor neurons, they are involved in motor function. And so you need both an upper motor neuron and a lower motor neuron to move the limb. And that's why we see paresis or weakness or paralysis with both upper motor neuron lesions and lower motor neuron lesions, because it requires both the mom and the child, or the supervisor and the worker, to be present for motor function. However, lower motor neurons themselves are tone and reflexes. So only lower motor neurons facilitate tone and reflexes. And so as we start looking at the effect of the upper motor neuron on the lower motor neuron, then it comes down to, well, what does the lower motor neuron want to do? So the lower motor neuron, by default, wants to make tone really high. Now, if I'm running a company and I am making a lot of product, what happens if too much product gets out in the market? It's bad for business, right? Because now we got to discount it, we got to make it really cheap. So we need to regulate production, because we got really good machines. We have built for 50 years down the road, right? We're ready for expansion, but not yet. And so we need to facilitate this tone function. And so what happens is the upper motor neuron provides overall, and we can get into the real weeds of this, but provides overall inhibitory signal to lower motor neurons. And so when the upper motor neuron sends a signal and says, hey, I want to make a movement, it's either going to increase or release that inhibitory signal. And there's whole other pathways. We talked about spinal, but there's about 3 or 4 other different pathways that are involved in different types of motor movements. And we won't get too far into the weeds on that for neurolocalization, but just be aware that there is more to the story. And so what we're going to see then is this upper motor neuron providing inhibitory input, and it's going to tone down our limbs. That's what allows our limbs to kind of be in this middle stage, right? They're not loosey-goosey, but they're also not in rigid extension. Because if I take a bat and I beat you across the skull, and I make you decerebrate or decerebellate because I've damaged the entire organ, what happens to our limbs? They go into extension, right? That's that decerebrate and decerebellate posturing. The big difference between the two, consciousness. The cerebellum has no effect on consciousness. The forebrain does. And so when I'm cut off from the forebrain, I'm unconscious, and that's usually because there's a brainstem lesion that's preventing the connection from the cortex to the spine. When the cerebellum is affected and I get decerebellate posturing, now I still have conscious awareness because my brainstem's intact, and that's where consciousness lies. So as we go through and we start talking about this effect, we can start make sense of, okay, if I have a lesion at C1, C5, what I've effectively done is I have damaged my inhibitory signal going to my thoracic limbs. And so if I damage the inhibitory signal, that's what's going to give me a little bit of that increased tone. And so with upper motor neuron signs, or sorry, a C1, C5 lesion, at the level of the thoracic limb, I probably should have done this differently, I'm sorry. Let's do this thoracic limb and pelvic limb. So at this level, I'm going to see upper motor neuron signs of dysfunction and upper motor neuron signs of dysfunction in both the thoracic and the pelvic limbs. All right, because what I'm doing is I'm damaging the inhibitory input to both my C6T2 lower motor neurons and my L4 to S1 or L4 to S3, again, depending on which framework you subscribe to, and it's equally affecting that signal coming down. And again, this is not an all or nothing situation. So I can have really, really nice light lesion at C1, C5 with maybe mild compression and not really see dramatic effects. And so that's why people will say upper motor neuron or normal. Because sometimes you just don't have enough damage to damage the inhibitory signal enough that it shows up clinically. This is all a spectrum in terms of damage. Now, that was a lot of information to kind of set us up for the next few lesions. So if we start now, we'll go and we move to lesion 2. Lesion 2 now, when we have that lesion affecting our cord, again, we're still damaging those upper motor neuron tracts, but we're also damaging these lower motor neurons. And so what we're going to see here at lesion 2 is going to be the lower motor neuron signs of dysfunction. And that's because we've damaged those lower motor neurons at the level of the thoracic limb. And we will then still see the upper motor neurons of dysfunction in the pelvic limbs. Again, they may also be, they're unlikely to be normal. When they are, if normal, think central cord syndrome. Central cord syndrome is when you have thoracic limbs that do not function, but your pelvic limbs are functioning. And it is as described. You have a lesion in the center of the cord. It's affecting those lower motor neurons, but it is sparing those external pathways. So remember, if that's my spinal cord, I'm going to have my, corticospinal tracts kind of hanging out over here. Depending on which literature you look at, we'll have some rubrospinal tracts kind of hanging out. All right, so they're kind of there in the center, but our lower motor neuron pathways live here inside of my butterfly. And so when we have that central cord syndrome, we truly are damaging more of that gray matter and sparing those external tracts as they move down the spinal cord. So they're still getting their signal through, but those neurons there in the center part of the thoracic spine are not. We'll see this with disc herniations that put a lot of pressure right up central. They're sparing those lateral spinal tracts and putting most of their pressure ventrally. And we'll see this with cancer, like lymphomas, gliomas that attack that gray matter in that central part of the cord. Sometimes you'll see it with inflammatory brain or inflammatory spine disease. However, that tends to be more multifocal and diffuse. But of course, it can happen. We have our classic T3L3 lesion. When we have that T3L3 lesion, no surprise. Oops, forgot to do this. 3, 4, 5. All right, when we have that T3L3 lesion, no surprise that we're going to have usually normal limbs in the TL. Right, I'm going to put a big asterisk because we're going to have Schiff-Sherrington, which can come in. And we'll come back and we'll circle and talk about that right at the very end. And then my pelvic limbs are going to show upper motor neuron signs of dysfunction. Again, they could have some normalcy depending on the degree of the lesion. It all depends. Because again, we can have just pain as the clinical sign, and thus we aren't seeing the signs of dysfunction. Then when we get to L4, I'm going to be specific here. I'm going to say that lesion 4 is going to be our L4S1. What we'll see here again is still, oops, change it to white, is still going to be our normal thoracic limbs. These lower lesions, and I'll explain this in a minute, are less likely to have Schiff-Sherrington. Schiff-Sherrington has a much higher association with T3L3, and I'll explain that in just a second. So as we have this L4S1, we'll see that, and now we will see are lower motor neuron signs of dysfunction in our pelvic limbs. Now, at the very, very, very start, I told you I was weird because I'm a pedantic jerk, and I split out S1, S3 as its own localization because there are lesions that affect either S1, S2, S3. More commonly, it affects the cauda equina. So it affects those nerve roots, that plexus of nerve roots that's coming out and traveling through L6, L7, S1, S2, S3, and into the tail. And so, again, very rare that we damage the actual spinal cord proper. When we damage the spinal cord proper, that's still going to be more your L4 to S3. That's why we present it that way. However, clinically, we have to realize that cauda equina syndrome is just an extension of S1, S2, S3. And so when we see this, the big thing that you can have is when you're either damaging just the tip of the spinal cord, which we can see with tail pole injuries and things like this. So people who say, well, that never happens, can go eat dirt. We're going to have normal limbs, all right? But what you're going to have is a gaping butthole. All right? You're going to have your lower motor neuron signs of dysfunction. We're going to damage that innervation to the anus. We're not going to have a perineal reflex, and we probably won't have tail function. All right? All that to say is that these animals can be walking and have normal proprioception when we have lesions at that very tip of the cord, or that more commonly cauda equina region. All right, so just keep that in mind. We'll talk about micturition in the bladder the third session that I'm with you at, so we won't deep dive into that because that's a whole nother talk. Before we kind of finish up, I do want to make sure that I quickly explain Schiff-Sherrington. And so Schiff-Sherrington, got to redraw Arthur. Looks like Arthur from the PBS show, which unfortunately, sadly, PBS going away. Won't get into that. All right. So when we look at this scenario, the reason that we get Schiff-Sherrington is because of middle management. So back here, between L1 and L5, we have middle management, or what you could think of as the step parent. Oh, and I should explain, for those of you who prefer the parent to child thought, I often think of this tone not as being a machine that has high functionality and high output, but as the radio being turned up way too loud, right? Because what does mom do? Turn down the radio. You're like, Mom. All right, and so you're going to turn down that radio, but when mom's away or damaged or dies, what's going to happen? The kids will play, right? And the radio's going all the way back up. So, and again, she just went out for milk. She's alive still. Don't worry. All right. Now we only have L1 to L5. Now this is middle management, maybe a step parent if you're using that analogy. And what's happening is these guys are providing inhibitory input. What color do we want this to be? Purple. To the thoracic limbs. So inhibitory input to the thoracic limbs. A great middle manager. They're saying and doing the same thing as those upper motor neurons, right? Those upper motor neurons are up there saying, hey, don't make too much product, or hey, turn down the radio if they're a parent. Well, these middle management are doing the same, but they are doing something weird. They're going against the flow of electricity, right? We always talk about downstream effects. Well, this is the one case where a downstream effect happens to have clinical outputs cranially. And so what you get when you have damage, and again, that damage is most commonly going to be associated with a T3 to L3 lesion. Because what's happening with a T3L3 lesion? I'm damaging not the neurons that live at L1 to L5. I'm damaging the axons that are traveling through T3L3 to get up to my C6T2. When we lose this input, what we get is increased tone only with shift Sherrington. Your proprioception is normal. Your motor is technically normal, but again, you have to read both of those through increased tone, and your reflexes are normal, which is also difficult to read through increased tone, right? But when you really test him and you're going through, you're like, man, this dog can move when I hold him up. He's ambulating well. He looks like he's got good strength. He just has this increased tone that's kind of affecting. And again, it can be severe enough to affect your reflexes. So sometimes you have to kind of go ahead and do the withdrawal, get that limb bent, and then do your reflexes on that limb. Now, why does this have a higher association with T3L3? It's because when I damage down here at maybe L4, L5, I still have 3 of the 5 middle managers providing that inhibitory input cranially, all right? And so that's why we don't always see it with these L4 to L5 lesions. Now, the lesions really delineate out, oop, that's L4, I can't go up there, heck no, right? But when we see this, we can say, okay, there's probably a T3L3 component. And remember that when you go to image, the spinal cord segments do not match up with the vertebral bodies, right? The further down we get and the larger the dog we get, the more our spinal cord kind of gets compressed there towards the end. So don't kind of fall into that, oh, the lesion's at L3, 4. It may still be affecting the caudal portion of the spine depending on the animal and how long the spinal cord is. The smaller the animal, or cats, the further down that spinal cord is actually going to end more naturally towards that L6, L7 region. All right, so that is a crash course and a lot of information to absorb onto spinal localization. Again, we'll talk about cranial nerves specifically and kind of more of the brainstem stuff as we go through. But I wanted to provide at least a general oversight, general thought, and a couple other tidbits, and more hopefully explaining the why behind some of these signs rather than just here's the signs, memorize them, and then know where the problem is. But hopefully this allows you to explain further a little bit about the why. And so I wanted to make sure I left enough time at the end to say, okay, did I lose you at any point? Do you have follow-up questions? Or have you seen something you're like, why does this happen? So I will open it up. I have the chat up for those of you in the Zoom, and then for those in the room, obviously, can just ask. So any questions? Give the Zoom a little bit of time to type just in case. So as you all think of questions or things, the one thing I'll add to it is a lot of people often ask about the cutaneous trunci. The cutaneous trunci, I view it as this. It is a reflex that I care about when it agrees with me. If the cutaneous trunci does not agree with everything else on the exam, or it doesn't agree with what I think is going on, it is the worst reflex and we should never use it. All right? And so it only matters when it agrees with me. As a reminder that when we have cutaneous trunci, Emma asked, how do I feel about cutaneous trunci in cats? Emma, I don't think I've ever actually gotten a cutaneous trunci in a cat. I used to have a neurologist that I worked with growing up and training, and she would go in, she's like, oh, it's there. And I'm like, that cat didn't move at all. I don't know what she's seeing. I just don't get it. And again, to me, cutaneous trunci, it's an additive test, right? Never will I base anything off of just the cutaneous trunci to say, yep, this is it, this is the lesion, right? Like the cutaneous trunci just does not have that presence about it. And so when we have that cutaneous trunci, yeah, I trust it as far as it agrees with me, and past that, I don't care. The Frenchies, right? Let's be honest, they were born with cutaneous trunci because I don't think they even get half of the innervation into their spine to begin with. And so when I don't get it on a Frenchie or I get it on a dog with disease, it just doesn't mean much to me. As a quick reminder on cutaneous trunci, because for some reason they get real caught up with this on boards, and I don't know why. It's not that important. But from a cutaneous trunci perspective, yeah, I can't pluck the guard hair. Yeah, that whole pluck the guard hairs to get cutaneous trunci in cats is, well, let's just say I don't know. So we're going to have our lower motor neurons for the cutaneous trunci living out here at C8 to T2 roughly. And you'll hear different variations on that depending on who you talk to, what literature you read. But for most purposes, it's going to be in that caudal cervicothoracic region. Remember that when I take my hemostats and I start pinching, I'm going to pinch the skin here. Remember that sensory innervation to the spine, if I'm pinching here, my innervation from that skin is actually going in at the level anywhere from 1 to 4 vertebrae cranial. We often say about 2, that's where it averages out, but you can get individual variations between that. And so then what it'll do is it'll go through the spinal pathways, oftentimes that spinal thalamic, a few other nociceptive and other types of receptive pathways. And it's going to go up here in C8 to T2 to these lower motor neurons. These lower motor neurons then are going to send out via the lateral thoracic and then innervate that panniculus muscle that causes the quivering. Now, what's important to remember is that when I stimulate one side, this then becomes a bilateral motor movement. And so when we stimulate on one side, we're going to actually get a response bilaterally. Because up here at the level of C8T2, there's a lot of cross communication between the neurons. And so both sides fire when we get that. And that same cross is the same reason we get that crossed extensor. Remember that crossed extensor is a sign of chronic upper motor neuron dysfunction. So if I have a Great Dane or a large breed dog that has cervical spondylomyelopathy, they come in and they've had this chronic nastiness going on in their neck for a long time, maybe up at C1, C5. We lay them down, and then all of a sudden we ask them to withdraw the top leg, and then that bottom leg shoots out. That's that crossed extensor reflex. Doesn't tell us much other than there's an upper motor neuron lesion and that it's been going on for a long time. Because what you're seeing there is you're seeing your lower motor neurons getting really lonely. And this is the same reason that in chronically paralyzed pets, when you pet them or you touch their toes or you try to bladder express them, their limbs start moving and their tail starts wagging and people lose their minds because he healed. No. What we're dealing with actually is really lonely, clingy lower motor neurons. All right? Lower motor neurons are like that bad ex who just won't leave you alone after you break up with them. And they're like, oh, I love you so much. And you're like, just leave me alone, bro. Well, these lower motor neurons get really, really lonely. And so they're going to make some decisions that they wouldn't normally make. They're going to take anything that they can get. And so when we have the skin get stimulated or the body gets stimulated and we get the sensory information that comes in and these lower motor neurons are present but have no upper motor neuron input, well, now they're going to say, are you my friend? Will you be me? You want to get married? Right? Like they're going to overreact to everything. And that's why we get this mass reflex. That is the reason that we get this crossed extensor. That's why you will see the motor movements with animals who are chronically paralyzed but do it. Now, sometimes we can leverage that, right? And we can get spinal stepping, spinal walking, and things like that. However, that typically is only going to be for small breed dogs that have good tone. And there is some thought that you can train into it. I'll tell you realistically, I think it's random as to which dogs will spinal walk and which dogs won't. There's never been a one I can predict. I definitely, when they have good tone and they can stand there, I say, hey, I think there's a chance. So keep doing these exercises, keep trying to get them to use that core and get that core up. But again, there's no way to predict it because some of it does play into how they handle these patients and how much degree of the spinal cord is damaged. All right, y'all. Well, that was a lot of quick information. Again, kind of just a quick synopsis, quick reminder about spinal localization, kind of those big tidbits, and more importantly, the underlying why, because I think that can help inform and help you remember and think through, okay, why is this clinical sign showing up? Why is this presentation the way it is? The one final thing I'll leave you with is this idea that, remember, a lot of this idea that, okay, we're going to have pain, then proprioceptive deficits, and then we're going to lose motor function, and then we're going to lose deep pain sensation. That's all predicated on compressive lesions, IVDD, tumors like meningiomas. That's all under this idea that the spinal cord is going to be compressed and that we're going to do it. When we have lesions that affect the inside of the spinal cord, intramedullary lesions, strokes, intramedullary tumors, things like that, that whole pathway of pain, then proprioception, then it goes out the door, right? Because no longer are we compressing the spinal cord and affecting the big lesions and, or sorry, the big axons and the heavy myelinated. No, we're damaging them at where they are, right? So we're being more specific to damage. And so you can see, like that central cord syndrome, just motor deficits with normal proprioception. And that's where it gets really, really hard. Thankfully, it's really, really uncommon to see that. We think that there's probably a version of that where the tail functions and the pelvic limbs don't. That's like a butt central cord syndrome. I've seen a couple cases. So if you ever got a dog that's paralyzed and wagging its tail, let me know, because we're working on a case series. But that's all I kind of have for you guys. Again, if you have any questions, I'll hang out here the last few minutes. But otherwise, thanks for hanging with me. Hopefully it was informational to you. And like I said, next time we meet, we're going to start talking about more neuroanatomy, but specifically around the brainstem, forebrain, and those clinical signs. All right, y'all? Have a good one. You're very welcome, y'all. Hey, just check and see if there's any questions. Y'all may have had to pop out to see cases or things, but just check and see if there's any questions before I leave.
I don't think so. On the other friend who published an article, you said, I know this person.